Toxic Toxic megacolon is a rare but severe complication of colonic inflammation, typically associated with inflammatory bowel diseases, IBD, like ulcerative colitis or Crohn's disease, as well as infections such as Clostridioides difficile colitis. It is a life-threatening condition characterized by acute severe distension, dilation of the colon, and systemic toxicity. Pathophysiology. Toxic megacolon occurs due to excessive inflammation in the colon, leading to 1. Loss of colonic muscle tone. This results in reduced motility and an inability to expel gas or feces. 2. Inflammatory cytokine release. The inflammatory response triggers widespread damage to the colonic mucosa, vascular permeability, and necrosis. 3. Systemic toxicity. The bacterial translocation across the damaged mucosa may lead to sepsis. Causes. 1. Inflammatory bowel diseases, IBD, ulcerative colitis, most common, Crohn's disease. 2. Infections. Clostridioides difficile colitis, pseudomembranous colitis, cytomegalovirus, CMV colitis, bacterial infections, e.g., Shigella, Salmonella. 3. Other causes. Ischemic colitis, radiation colitis, medication-induced, e.g., opioid use causing ileus. Symptoms. Toxic megacolon presents with both local gastrointestinal symptoms and systemic features, including severe abdominal pain and distension, fever, tachycardia, dehydration, hypotension, shock in severe cases, altered mental status, bloody diarrhea or absence of bowel movements, paralytic ileus. Diagnostic criteria. The diagnosis of toxic megacolon requires 1. Radiological evidence of colonic distension, colonic diameter 6 centimeters on abdominal X-ray or CT scan. 2. Systemic signs of toxicity such as fever, 38.6 Gauss Celsius, heart rate 120 bpm, leukocytosis 10,500 millimeter or leukopenia, anemia, dehydration or electrolyte disturbances. Complications: colonic perforation leading to peritonitis, sepsis, shock, multi-organ failure, death if untreated. Diagnosis: imaging, abdominal X-ray shows marked colonic distension, CT scan helps identify complications like perforation or abscess. Laboratory tests: complete blood count, elevated white blood cells, anemia. Serum markers: electrolyte imbalances, elevated inflammatory markers, e.g., C-reactive protein. Stool studies: identify infectious agents, e.g., C. difficile toxin. Hash management: 1. Supportive care, intravenous fluids to maintain hydration, electrolyte correction, nasogastric decompression for bowel rest. 2. Medications, broad-spectrum antibiotics to prevent bacterial translocation, corticosteroids in cases of IBD-related toxic megacolon, discontinuation of antidiarrheal or immunosuppressive medications, e.g., opioids, antimotility agents. 3. Infectious causes, antibiotics targeting the identified pathogen, e.g., oral vancomycin or fidaxomicin for C. difficile. 4. Surgical intervention indicated if medical therapy fails within 24 to 72 hours or in cases of perforation or peritonitis. Procedures include subtotal colectomy with ileostomy. Prognosis: early recognition and treatment improve outcomes. Mortality rates are high in untreated or delayed cases, particularly in those with perforation or sepsis. Prevention: prompt and adequate management of underlying colonic diseases. Early treatment of infections like C. difficile, avoidance of medications that exacerbate colonic distension. This condition requires emergency management and close monitoring in a hospital setting.